Hi everyone, I'm Dr. Ng. I'm going to talk to you about maternal resuscitation, and these slides are adopted from SALSO. The goals of this tutorial is for you to understand the issue related to maternal collapse, to learn how to do a proper resuscitation, achieve competence in maternal resuscitation. Cardiac arrest is fortunately a rare event in pregnancy, and the most common direct cause of maternal death was thromboembolism, which results in cardiac arrest. And a fast and effective resuscitation will determine the outcome of both mother and fetus. The causes of maternal collapse includes the 4H, 4Ts, and 1E. So the 4H are such as hypovolemia, which includes your obstetric hemorrhage, can be bleeding because of PPH or APH. You can also have other shocks such as neurogenic shock in uterine inversion, or you also can have septic shock. As for hypoxemia, the conditions such as acute pulmonary edema, myocardial infarction, or peripartum cardiomyopathy, or those who have aortic dissection. As for hypo or hyperkalemia or other electrolyte imbalance, usually is because of non-pregnancy related causes such as those underlying medical diseases and hypothermia. And not to forget, hypoglycemia is also one of the reversible cause for loss of consciousness. As for the 4Ts, which includes thromboembolism, under thromboembolism you have pulmonary embolism, you also can have deep vein thrombosis, can have amniotic fluid embolism and air embolism. And for the management for thrombosis, you will need, for those DVT or pulmonary embolism, you will need a therapeutic dose of low molecular weight heparin or IVI infusions of heparin, or even a thrombolysis for severe pulmonary embolism. As for amniotic fluid embolism and air embolism is mainly supportive care. For toxin, the toxicity such as local anesthesia, okay, then your antidote will be intralipid. Anaphylaxis is also considered under toxin. Magnesium sulfate toxicity, which your antidote is the IV calcium gluconate, 10%, 10 cc over 10 minutes. All right, so these are the reversible 4Ts. The other two, not so common, is tension pneumothorax and cardiac tamponade, which you can see in patients that has trauma or attempted suicide. All right. As for eclampsia, preeclampsia, they can also present with maternal collapse. If you realize that the adult BLS training has now shifted to DRCAB rather than DRABC, meaning that the circulation comes before airway and breathing. So a cardiac arrest should be recognized when someone is unresponsive and there is absence of normal breathing, meaning that if you have a patient which is unresponsive and they are gasping and having agonal breathing, then this is actually an indicator of cardiac arrest, and you should start chest compression immediately without even you check on the carotid pulse. All right, and the chest compression should begin immediately, and it should be a high quality and uninterrupted chest compression. And when you do, and if let's say it is a shockable rhythm and you shock the patient, after you shock the patient, you should continue with chest compression immediately, rather than you shock the patient and then you wait and check for the pulse. This is a workflow of how the resuscitation are, which is also should be quite similar for maternal resuscitation, which you need to recognize and you need to activate, meaning that you need to activate code blue in a maternal collapse. And also, once you recognize the patient is in unresponsive and having abnormal breathing, then you should perform early CPR and wait for your defibrillator to be here. If your defibrillator is here, you apply the pad and you see whether this is a shockable or not shockable rhythm, and then you follow the ALS workflow and also post-cardiac arrest care. There's slight difference in terms of maternal resuscitation as compared to a normal adult resuscitation, and the challenges are as such, whereby there might be difficult in intubation in pregnant women and especially in obese lady, and there's also increase in risk of aspiration, and there's increase in rate of hypoxia due to diaphragmatic splinting and increase in oxygen consumption. and there's the blood loss rate is actually higher because there is increase in cardiac output in pregnancy, and it is a hyperdynamic circulation during pregnancy. It's a physiological changes. And for those that who has a uterus size for more than 20 weeks, you will have this aortic cover compression, which actually reduce your cardiac output by 30 to 40%. And this major aortic cover compression should be highlighted later, that I will talk to you about resuscitative hysterotomy. So when we talk about DRABC, what are the things? D is for danger. You need to protect yourself from danger. You need to wear your PPE, and you also need to avoid spillage, and you need to identify whether there is unstable bed and trolleys, especially you are going to perform a CPR for the patient. And you also have to protect patient from danger. As for R is for response, and you need to call the patient, hello, hello, are you okay? And if there is no response, you need to call for help. So in our hospital, for maternal collapse, we call for cord blue adult. And when you assess the conscious level, you can see whether the patient is alert, whether the patient responds to voice, responds to pain, or unresponsive, which is what we call as AVPU. And you can use your Glasgow Coma Scale as well. For airway, you need to open the airway. So it's used to be done by head, tail, chin lift, or you do a jaw thrust. And you can also secure the airway by using an oropharyngeal airway or a laryngeal mask airway. As for the airway, you can also use advanced adjuncts such as intubation, especially when you need to perform CPR for the patient. For breathing, you need to assess the breathing. You look for any evidence of abnormal breathing or whether the patient is gasping or not. So it is no longer what we call as look, listen, feel. You look at the chest and see whether the patient is breathing or not. And then you see whether the patient can breathe as normal or not. If it is not normal, the patient is most likely in cardiac arrest. So if the patient is breathing, the patient is unconscious, not responsive, but the patient is breathing normally, you can put the patient into a left lateral position and give him or her oxygen. And you need to check the vital signs regularly and assess and treat the cause. Why is the patient unconscious? So this is the recovery position. Okay, you put the patient into a lateral position, and the head has to be dependent, meaning that something has to support the head, and the position has to be stable. But if the patient is not breathing, or if the patient is breathing abnormally, or the patient is gasping and unresponsive, you should start the chest compression immediately. As for circulation, when we talk about chest compression, it has to be a high quality chest compression. So the location is no longer using the nipple line as the landmark. It actually should be at the lower half of the sternum, and your heel has to be at the center of the chest and with another hand on top. Looking at this palm, okay, this is the lower hand. This lower hand shouldn't be covering down here. It should be like this, in this position, and using the heel of your hand to be in contact with the patient's sternum. Okay, and the rate should be at least 100. Usually it's 100 to 120 beats per minute. And you should change the person if you feel tired. And in pregnancy, something very important is that we talk about this lateral tilt. Okay, so last time we used to say we want to tilt the patient. You put some pillow or you tilt the patient into a 15 to 30 degree because your aim is to relieve the aortic cover compression. All right. However, now we no longer recommend tilting the patient with a flat board because it is very difficult to perform a CPR in that position. So what we do now is we actually do a left uterine manual displacement. So you can either use a two-way method or a one-hand method. Okay, the two-hand method is you pull the assistant will stand on the other side and pull the uterus towards the left side. Okay, whereas for one hand is you stand on the right of the patient and you push it towards the left side. But you have to be very careful not to push downwards, because if you push downwards, you push the uterus downwards, and the aorta is just behind the uterus, and you are going to cause more harm. As for the rate and the ratio, it should be a 30 to 2 compression to breath ratio, and you have to continue until the advanced life support has arrived. So you can do this as 5 cycles, and then at every 2 minutes interval, which is your 5 cycles interval, then you can pause for a while to check for pulse. As for the ventilation, before you can have, as I mentioned earlier, before you can have intubation, you can actually use the bag valve mask or NBU bag to provide ventilation or provide oxygen. You only use mouth to mouth if, let's say, that you didn't have this NBU bag, or you didn't have this mask. And remember to use protective devices for mouth to mouth ventilation. And this is what we talk about, DR, S, A, B, C, D. D is actually defibrillator in this situation. Okay. So another special things in maternal resuscitation, apart from when you do the CPR, you need to manipulate the uterus to the left, which we call it as left uterine displacement. The other thing is about resuscitative hysterotomy. Okay, it is part of the resuscitation. The aim of doing a resuscitative hysterotomy is to save the mother. Okay, it's not to deliver the aim is actually not to save the baby, but is to save the mother, because you want to relieve the compression on the aorta cava. All right, so if the maternal collapse has been more than 4 minutes and there is no signs of ROSC, then you should perform a resuscitative hysterotomy, or what we call as a perimortem hysterotomy after 4 minutes. And who, where, and how to perform? Okay, this resuscitative hysterotomy should be done as quick as possible. You no need to move the patient to operating theater. For example, you have a patient who collapsed in the maternity ward, okay, and CPR has been initiated. Code blue has been activated and CPR has started. So after 4 minutes, you no need to move the patient to OT to do this resuscitative hysterotomy. All you need is just a scaper, because there is no circulation. The heart has stopped pumping, so by right there should not be much bleeding. And we actually have a resuscitative hysterotomy kit placed in the labor ward, so that it has the simple equipment that we need to use to perform this resuscitative hysterotomy. Alright, as for the incision, it will depend on the surgeon's preference, whether it is a lower midline or it is a phalansteal incision. Okay, we only do this resuscitative hysterotomy for those who has the uterus size of more than 20 weeks or more. So if you have a patient who is 12 weeks pregnant, then we don't do the resuscitative hysterotomy, because the uterus is below the umbilicus. So it is less likely that it will cause compression to the aorta cava. So as a summary, so we go back to DRS ABC, even though I say ABC because it's easier to remember, but you have to know that chest compression should be initiated when the patient is unconscious and also having absence of normal breathing, meaning that if you have a patient who is unconscious and the patient is gasping, then you can already start chest compression. Okay, so danger, response, shout for help, airway, breathing, circulation, and D is for defibrillator. Left uterine manipulation for patient who has a uterus size of more than 20 weeks. If you didn't know how many gestation is the patient, never mind. Look at the umbilicus, whether the uterus is above or below the umbilicus. If the uterus is above the umbilicus, yes, the patient will need a left uterine manipulation and also a resuscitative hysterotomy if the CPR has been lasted for more than 4 minutes. Okay, and the causes of maternal collapse, which are 4H, 40s, and also 1E. With that, I thank you for your attention.